Good morning. I'm Brent Roussin, Manitoba's Chief Provincial Public Health Officer. I'm very pleased to be joined by Dr. Marcia Anderson, Public Health Lead for First Nations Pandemic Coordination Team. Today, the province is announcing that it's expanding recommendations for a third dose of COVID-19 vaccine to include First Nation people living on reserve. Dr. Anderson is going to speak more to this in detail. But I want to offer a few other comments before turning things over to Dr. Anderson. As we gear up for the fall influenza campaign, I wanted to highlight that Manitoba COVID-19 and influenza vaccine shot finder is now live. This online service provides a way for Manitobans to search for locations to offer either COVID-19 vaccine or influenza vaccine in your area. The map can be found at protectmb.ca and manitoba.ca/vaccine. In some locations, as indicated on the website, walk-in appointments are available. Once you have found a location near you, you can book your appointment online or by phone. One way to increase your wellness this winter is by getting the seasonal flu vaccination. All Manitobans over 6 months of age are eligible for the seasonal flu vaccine at no charge. Influenza is especially important to those at increased risk of severe outcomes and their caregivers and close contacts. So being immunized against seasonal flu protects yourself, those around you, our communities, our healthcare system. Going and getting that flu vaccine is yet another way to help Manitoba fight against COVID-19 and the pending respiratory virus season. On September 24th, it was announced that some public sector workers must be fully vaccinated by October 18. Today is October 18. The introduction of rapid testing requirements for individuals in specific sectors who are not fully vaccinated is an important additional protection for the vulnerable populations who are at greatest risk of the impacts of COVID-19. Vaccines are our best protection against COVID-19. Again, it protects us and the people around us. So I want to thank all the Manitoba public sector workers for their ongoing efforts to protect vulnerable Manitobans and their colleagues. The best protection against COVID-19 is to get vaccinated, to get tested, and to follow public health orders designed to keep you, your family, and community safe. So specific data related to the number of unvaccinated teachers or healthcare workers or the number of rapid tests available is not something that I'm able to provide. I direct such questions to Shared Health or to Manitoba Education for specific numbers. I continue to encourage all Manitobans to get vaccinated, both for COVID-19 and for influenza. And this has really changed our trajectory here in Manitoba. And so I encourage you to get vaccinated if you haven't already. Speak to a healthcare provider if you have questions. But we really need Manitobans to continue to get vaccinated. And so thank you. I'm going to pass it over to Dr. Anderson.
Thank you, Dr. Roussin. Good morning, everyone. I'm Dr. Marcia Anderson, the Public Health Lead with the Manitoba First Nations Pandemic Response and Coordination Team. We have seen throughout this pandemic that First Nations people are disproportionately impacted by COVID-19. The fourth wave is no different. First Nations communities are seeing breakthrough cases of COVID-19 among people who are fully vaccinated. The risk of a severe outcome remains much, much lower for vaccinated individuals than for unvaccinated people, although we are seeing some severe outcomes in fully vaccinated people as well. Due to the context within First Nations communities, it's essential that we decrease transmission as well as preserve our local healthcare capacity. I will be sharing some data that shows our current immunization rates, epidemiological and surveillance data, and the stories of 3 First Nations communities all affected by COVID-19 outbreaks recently. If we could have the slides, please. Thank you. As Dr. Roussin had said, we are expanding third dose eligibility today to First Nations people living on reserve. These third doses will be administered at least 6 months after the second dose, which means as of today, approximately 7,200 people will be eligible. If you go to the next slide, please. This slide does show where eligible people can find vaccines, as well as the flu shot finder that Dr. Roussin had mentioned. You can go to the next slide, please. And the next one. So our briefing today is a little bit earlier than usual, and so we don't have today's data update yet. However, as of October 15th, there had been 36 new cases of COVID-19 among First Nations, representing 39% of all cases in the province. As you can see, 31 of those 36 were on reserve. We are also seeing rising hospitalization numbers. As you can see, as of Friday, there were 28 First Nations people in hospital and 5 in the ICU. Test positivity on reserve is significantly higher than throughout the province at 10%. Next slide, please. When we look at this epi curve, which shows First Nations COVID-19 cases by regional health authority, not surprising to anybody because this has been in the media already, but what we are seeing is a higher proportion of cases occurring within the Northern Health region. That being said, approximately 17 First Nation communities currently have active COVID-19 cases, and this includes communities located in every region of the province. Next slide, please. The vaccine rollout has overall been a remarkable success. Almost 200,000 doses of COVID-19 vaccine have been provided to over 105,000 First Nations people. This gives us coverage with at least one dose of over 93% on reserve, with 82.6% being fully vaccinated. And off reserve, there continues to be significant improvements in coverage, currently just over 70% with at least one dose, and 64.5% who are fully immunized. We certainly want to congratulate and thank the work of urban Indigenous vaccine clinics, community organizations, and FIT team partners who are working hard throughout the province to meet people where they are at. Even as we are talking today about booster doses, it's critical that we recognize the effectiveness of this vaccine. The graph on the top shows severe outcomes amongst unvaccinated people, while at the bottom, it shows those severe outcomes amongst fully vaccinated people. And we see how there continues to be much lower risk among First Nations people of severe outcomes in those who are fully vaccinated. Next slide, please. However, as our cases start to rise throughout the First Nations population, we are also starting to see a higher number of breakthrough cases. When we consider this, it is again important to keep in mind that these are not rates. The absolute rate of COVID-19 cases amongst those who are fully vaccinated, as our colleague Dr. Tam has said, remains about 10 times lower than in those who are unvaccinated. If we can go to the next slide, I will share the experience of some of the communities who have had recent outbreaks. This community began experiencing an outbreak on September 3rd, and it is ongoing. Slide. You can go to the, there we are, thank you. This is showing the age breakdown of overall cases, and so we can see the high number of the cases are occurring in people who are not yet eligible for the vaccine. In fact, of the 171 total cases, 47 or 27% were in people not yet eligible. On the right-hand side, you can see the age breakdown among cases who are fully vaccinated. Next slide, please. I want to highlight that although there have been 4 severe outcomes, 4 people experiencing severe outcomes within this outbreak, that none of those severe outcomes occurred in people who were fully vaccinated. However, fully vaccinated people are making up a significant proportion of cases amongst those who are eligible, and this is contributing to transmission in the community and adding significant workload to the local workforce. Next slide, please. We also are paying attention to when cases who experience a breakthrough infection after full vaccination received their second dose. And as you can see, the largest proportion or the largest number of these cases received their second dose in May. Next slide, please. The second community had an outbreak beginning on September 19th. And again, in this community, we notice a high proportion of people who were cases were not yet eligible for the vaccine. The younger age structure in First Nations communities means that we will have proportionally more susceptible people who are not yet vaccine eligible. We go to the next slide. Of the 109 cases in this community, 63 were eligible to receive the vaccine. And of those, 36.5% were fully vaccinated. I'll just wait for the slides to catch up here for a moment. Another 8 people were partially vaccinated, and about half of those eligible had not yet been vaccinated. And then of those cases who had been vaccinated, we can see that most of them received their vaccines in March, we're about, I should have counted this ahead of time, 7 to 8 months out from those second doses. The other thing that I'll just mention when we're looking at these graphs is in First Nation communities, we had a pattern of mass clinics. So with our rollout, we had the elders who were eligible first, and they were eligible generally, I would say, February 1st dose, March 2nd dose. And then we started with the 18 plus rollout. And so everyone in the community 18 and over was eligible. So we will see these clustering of cases around when those mass clinics were held in community, which would be different than if we looked in the general population, where eligible cases would have been spread out more by age over time, as opposed to by community over time, which is what we see here. Go to the next slide, please. This will be just the third outbreak that I'll share some information on. This outbreak began September 27th, so it is a newer outbreak. Again, a high proportion of the cases occurring in people not yet eligible for vaccine. Next slide, please. Of the 12 cases that occurred amongst people who were eligible to receive the vaccine, 100% of them were fully vaccinated. And again, I want to highlight that the prevention of severe outcomes is a critical success of the COVID-19 vaccine and remains a success in First Nations people who have received the vaccine as well. However, this does contribute significantly to community infrastructure, for example, when fully vaccinated cases have to isolate, as well as putting strain on the local health workforce. If we go to the next slide, please. Most of the people who experienced a breakthrough infection in this community had been vaccinated in April or earlier, so 6 or more months ago. Next slide, please. This slide is showing the proportion of breakthrough cases in the province that are experienced by First Nations people. Keeping in mind that we make up roughly 10% of the population, what we can see is that the proportion among breakthrough cases, hospitalizations, ICU outcomes, and fatalities remains higher after vaccination. This is why it's important that we analyze both the published evidence, the emerging evidence around COVID-19, as well as contextualize that to First Nations communities in Manitoba based on our specific pandemic. And given what we already know about the risk conditions that make the COVID-19 experience different in First Nations communities. This graph is showing that the proportion of breakthrough cases in Manitoba that are experienced by First Nations compared to the rest of the province has been increasing since August. What is unclear is how much of this is due to waning immunity versus the underlying risk conditions in First Nations communities, such as overcrowded housing, overcrowded classes in schools, which may be a factor, food security, and what the combination of those factors are. Next slide, please. Consistently, about 2/3 of breakthrough infections being experienced by First Nations people are in people who usually reside on reserve. Next slide, please. This is our vaccine coverage timeline. And so considering today is October 18th, I believe, if we look back about 6 months, that would mean people who received their second dose prior to April 18th would now be eligible for the vaccine. Functionally, this will be elders, so roughly people aged 60 plus in remote isolated communities and 70 plus in non-remote communities, as well as healthcare workers. As we move towards the end of the month and into November, more First Nations people will become eligible as 6 months after their second dose will have passed. The green bars represent people who received Moderna. That was the predominant vaccine that we used on reserve. The blue are people who received Pfizer, and this would start to include the off-reserve First Nations population as we go farther along out, as well as youth on reserve who received Pfizer. So just to explain what that graph is showing us. So as I mentioned earlier, we estimate this will be about 7,200 people as of today who are eligible for the vaccine. And most of them will receive the same vaccine they received for their first 2 doses, so largely Moderna. The Integrated Vaccine Operations Center, or IVOC, which is co-led by First Nations through Ongamazin on behalf of Manitoba First Nations Pandemic Response Coordination Team, as well as the federal government, is being stood back up and will lead the 3rd dose rollout. Fortunately, we have the experience that we've built since January in delivering vaccine across the province to the 63 distinct First Nation communities. Work is underway this week to identify the number of individuals in each community who are now eligible for this 3rd dose. We are also working on community-level reports of the number of people who need either their first or second dose to be fully vaccinated, because we know that every dose of the COVID-19 vaccine is important. IVOC will support community leadership, as we did in previous phases of the vaccine rollout, in implementing clinics at times and locations in the community that will work best. As this phase of the vaccine rollout will be occurring concurrently with the public health management of COVID-19 cases or outbreaks, the flu vaccine campaign, as well as regular healthcare needs, we understand that surge support will likely be necessary. And again, IVOC will help to coordinate that. With that, we are ready to take questions.
Established before that other BIPOC communities also have a really high rate of infection. Why are we not including them as part of this recommendation?
Yeah, it's a great question. So we will certainly be looking at that data specifically. As you know from our previous presentations and data, it would be few who would at this point be eligible because 6 months will not have passed. So we look forward to reviewing the data, working with our colleagues, Dr. Reimer, Dr. Hilderman, Dr. Roussin, on when and how that recommendation should move forward as well.
The communities where you are seeing a greater proportion of breakthrough cases, do you find that they have high overall vaccine coverage or like middling vaccine coverage? I'm just wondering if that's, and if there's more exposure among unvaccinated people that might be contributing to breakthroughs.
Yeah, so in 2 of those communities, coverage is around 90% actually, and in the 3rd community, coverage is around 70%. So vaccine coverage, I would say, it's good overall actually. But like I mentioned, because of the age structure, even with a small number of unvaccinated people, the total number of susceptible people remains higher.
And what, is there anything else that could be driving the increase in like proportion of breakthrough cases, like other than length of time between since their second dose?
Yeah, I think we need to be considering both the length of time as well as the underlying factors that have made First Nations people at higher risk overall. So those underlying factors like crowded homes with poor ventilation really increase the intensity and frequency of exposure. One of the things Dr. Roussin and I were talking about earlier is how viral loads, the amount of virus or the dose of the virus that you get when you're exposed, does increase your chance of getting an infection infection as well as a severe outcome. And so the combination of potentially time since vaccination as well as higher viral load because of these factors is, I think, what we're seeing here.
Is there any patterns where children who are ineligible, like not eligible to be vaccinated, are they passing on the source of the infection into vaccinated individuals? Is that a trend that you've seen on reserve communities?
So, I mean, when we look at the numbers, I would say yes, that likely has to be happening. It's not always very clear which is the first case in a household. We do see that among susceptible individuals, it approaches 100% who will become infected if cases continue to isolate in the home. So it's not always obvious, was it an adult in the home or a child in the home was infected first, if they all kind of test positive right around the same time. But likely that's part of what's happening.
I know you just sort of touched on this at the end, but there will be some level of transportation, like going to these communities to deliver the doses. Like how's that going to work in practice?
So the same thing that was done in our kind of first and second phase rollout, where we delivered vaccine to almost all of the communities. Some of the non-remote ones may work in partnership with RHAs or nearby adjacent communities to administer the vaccine, but it will all be done locally again. And because this is time-bound, so it will be 6 months after second dose, we'll likely follow the same scheduling that we did in the first and second phase rollouts.
Which is what again?
So in the second phase scheduling, it took into account factors like remoteness, risk of evacuation, distance and remoteness are pretty much the same thing, but those were the factors that determined the second phase sequencing.
You went to those communities first.
Yes.
And that would happen again. You mentioned sort of in this week we'll sort of determine which people are eligible first of all. Is there sort of a timeline when you expect to, be in half the communities or all the communities?
It will be complicated. I would say we will likely see third doses to those eligible available within the month to all 63 communities. That was roughly the length of time it took us in each of the earlier phases.
Is the recommendation that people receive the same product that they have
Yes.
the first and second dose?
Why is that the recommendation?
Dr. Roussin, did you want to speak to that?
Yeah, well, I mean, I think right now when we're first rolling out the vaccine program, supply was the big issue, right? So now supply really isn't an issue with either product. So we'll just stick with, we can provide the same product to everyone on what they first received.
When we heard about the third dose for healthcare workers, it was a Pfizer shot, right?
That was the vast majority of what they had received at that time.
So it's not about getting them a Pfizer shot, it's about sticking with the same one. That's more important?
I don't think that has a high level of importance. It's just the third dose is important. We know that the mRNA vaccines are highly effective. We know they're effective when the same products are used. We know they're effective when there's a mixed dose as well. So I think just out of just because we don't have really a supply issue, I think the decision was just for the most part we'll just provide the same dose that they received before.
Also, if I could just add to that one other factor which we discussed, which is people have become in large part comfortable with the product that they've received. And so there's also that reason why we would want to stick with the same product unless there's a compelling reason to provide a different product.
How are you expecting uptake to be for the third dose?
Yeah, I'm anticipating, based on what I've heard already from community leaders and First Nations community members, uptake will be good. One thing you'll have noticed is about 11% of First Nations people have received one dose, but not their second dose yet. So we really want to emphasize that we believe every dose is important, every dose is effective, and every dose is safe.
Why do you think it's that high? It's a bit of a larger margin than we see for the general population. I think 4 or 5%. You see the margin for the general population. Why do you think it's higher?
I think there may have been some system challenges over the summer with workforce capacity to administer some vaccines. And so we will, like I mentioned, increase the workforce supply that's available with some surge supports if that's needed. I do know there was also some concerns around second dose side effects. And so that may have caused some people to be hesitant or delay the second dose. So I think those are the two main factors. We'll certainly make sure we're out with our communications, emphasizing the safety and the effectiveness of the second dose, and in particular, what we've seen with Delta around how important that second dose is.
Will you take this time to go to the phone, actually, and then we'll come back to the room after. Thank you.
Thank you. A reminder to our reporters on the line, you will have one preliminary and one follow-up question. Up first this morning from CJOB, Rosanna.
Hi, doctors. Thanks for taking our questions. My first question is for Dr. Roussin. So a few months ago, I believe it was Dr. Atwal telling us that the province was updating testing so Delta and other variants of concern wouldn't take as long to identify. On our last update, there's a big proportion of the cases are still unspecified, and I'm just wondering why we're seeing that.
Yeah, and so we still have the ability to screen tests for being a variant of concern, and then certainly after that, the sequencing is a bit of a rate-limiting step. Where we're at right now, we see such a predominance of Delta that's circulating right now in Manitoba, so it doesn't really change our management of our response. We know variants of concern make up the great majority of cases, and Delta makes up the majority of those. So our public health response doesn't really change. All of this is still important, right? Because we could, we still need to surveil for new variants of concerns or changes in epidemiology, but this delay for sequencing isn't affecting our response right now.
Thank you. Dr. Anderson, I may have missed some of the answers because I can't hear so well, but with Norway House Cree Nation experiencing what the chief is calling its first wave, what specific kinds of help is the province offering these communities?
I'm going to have to actually defer to Dr. Roussin on help, but I can mention that they have already provided a couple of public health nurses to assist with the surge support. And then I'll defer to you, Dr. Roussin.
Sure, yeah, and so we do have rapid response teams that we've worked with many First Nations in the past to improve the public health response, in the surge. We will look at other types of help, public health orders if necessary, we could review as well. So there's been a lot of collaboration, and it continues for this First Nation as well.
From the Winnipeg Sun, Glenn.
Yes, Glenn Dawkins from the Winnipeg Sun. Dr. Roussin, how concerning is it that you mentioned that the numbers for healthcare workers and teachers, et cetera, those who will need to be either vaccinated or tested as of today, you don't have those numbers available. But how concerning is it that these healthcare workers either refuse to get vaccinated or don't wish to be tested? How concerning is that from a public health standpoint?
And so I think the evidence is quite clear on how effective and safe vaccines are, and it's really the best way for us to protect ourselves and the people around us. And it becomes even more important when you're working with vulnerable individuals, such as our healthcare system. And so we certainly encourage all health workers to be vaccinated. The evidence is clear in that regard. But if that isn't going to occur or occur in a timely manner, then we must protect those vulnerable patients by then testing. And so, we put this program in place for this very reason, to protect those who are at most risk. And, we really need the support of everyone who sees themselves as a healthcare worker, right? Being a healthcare worker is a privilege, right? To be there for people in some times of their greatest need. But with that, it comes with many, many responsibilities. and protecting them is one such thing. So I'd encourage all healthcare workers to certainly protect the people they care for, and that's with vaccine. And if that hasn't occurred yet, then it'll be testing.
This question is for Dr. Anderson. I believe you answered this earlier, although your answer was clear, but the question wasn't. This program for third doses for on-reserve First Nations individuals, do you perceive it also expanding to off-reserve First Nation individuals, and when might the timeline for that be?
So I believe about 2 weeks ago in the vaccine briefing, Dr. Reimer mentioned that she anticipated boosters being announced before the end of this calendar year. Perhaps Dr. Roussin can clarify that. So we will continue to review the data in breakthrough infections for off-reserve First Nations as well as other populations and work with them on the most appropriate timing of that announcement.
From CBC Radio Canada, Emile.
Yes, hi. My question is for Mr. Roussin. So are you considering additional measures besides vaccination in Indigenous communities?
So this is something that I've never approached unilaterally, right? It's all in collaboration with Dr. Anderson, with the leadership in those communities, and so we will continue to, provide, our advice if it's sought, and our help if it's requested. So there's always the further public health measures that are available, and we'll consider that if it's deemed necessary.
All right, thank you.
From the Canadian Press, Steve.
Hi, Dr. Roussin. About the testing capacity for those healthcare workers and other frontline workers who are not fully vaccinated as of yet, and as of today they have to be frequently tested. Is the testing capacity in place across the multiple sectors where this takes effect?
Yeah, and so again, for the the details about how many tests are available for each area, I don't have those specifics, so you can direct it to those specific areas. But certainly we've anticipated the a significant amount of capacity that will be required to implement this, and a lot of work's been on this. We've announced it quite some time ago, so it's given a lot of lead time to be able to have this implemented properly. So I believe the capacity is there, but I don't necessarily have the specifics of that.
Okay, and Dr. Anderson, you mentioned about 7,200 people who live on First Nations are now eligible for this new expanded third dose recommendation. That's a small percentage of the on-reserve population, so I just want to make sure I understand correctly. The 7,200, is that the people who are eligible now because they would have received their second shot 6 months ago, and you expect that number to increase as time passes, or is that the total amount you expect to be covered by this?
That's the approximate number of people who are eligible today as of the announcement. And as time passes, more and more will become eligible as soon as they pass their 6 month after second dose date.
Thank you.
From CTV Winnipeg, Michelle.
Hi, Dr. Anderson. I wanted to ask you about the two potential reasons why we're seeing breakthrough cases or more cases now. You said one is potentially waning immunity, which we're doing something about with third doses. The second was, the conditions or, systemic problems. What would your recommendation be to address that second part? Like, what can we do now or start doing now to start addressing, overcrowded housing and those kinds of things?
Yeah, it's a great question. Sometimes we refer to this as healthy public policy, where we look at the other types of public policy that create the conditions in which people can be healthy. So I do think it's around looking at what investments or housing policy may help alleviate the housing crisis, particularly on reserve. And when we consider the off-reserve population, similarly in parts of the province where First Nations people are more likely to live off-reserve, I think, we might want to consider what income policies would be supportive, what food security measures need to be in place. And always when we think of First Nations communities, we're going to think about the water supply and ensuring everybody has access to clean drinking water. One of the things community leaders have asked me about repeatedly has been the kind of capital costs or requirements to improve ventilation and crowding in First Nations school systems, where classroom sizes also tend to be larger. So those are all the type of public policy decisions that we could be looking at, reviewing the evidence for, providing some suggestions potentially to those who make those types of decisions when we look at creating overall conditions that would both reduce the risk of COVID-19 exposure, but also provide other health benefits as well.
Thank you. When you were talking about the data, you were mentioning people who are not yet eligible. Is that children? And can you speak to how many of the cases on First Nations are happening in children?
Yeah, so the not yet eligible would be those 11 and under for whom the vaccine has not yet been authorized for use. And, across the communities right now that I referenced, I would anticipate about, on average, 30% or so cases are occurring in kids 11 and under.
From CHVN, Taylor.
Hi, good morning. Dr. Anderson, can you give us a brief overview of what it looks like for a reservations healthcare system when there are multiple COVID cases?
Yeah, it's a great question. So the first thing I would say is the jurisdiction or the organization running the healthcare system will be different or can be different from community to community and even within a community. So Norrie House has been in the news and talking about their outbreak. For example, the federal government runs that hospital. It's one of the few remaining Indian hospitals left in Canada. The clinic operations have been transferred to the community. Public health has been transferred to the community, which means it's community operated at that level. And then Ongamazin Health Services at the University of Manitoba supplies the physicians. So we have at least 3 different partners contributing to healthcare within that one single community. And then, as I mentioned earlier, there have been public health nurses from the province to support the response. And so that gives you an idea of how complex the jurisdictional environment can be. In remote communities, in most cases, there would be a nursing station, which is nurse-managed primary care with itinerant physician services and then backup. And then in many of the non-remote communities, it's a health center which delivers public health, which may be transferred to operation of the community or may be run directly by FNIB. And they receive primary care and other services largely through the regional health authority systems. So a large part of what we have to do is actually coordinate who is doing what and who is responsible for what. In a small community where there may be only 2 or 3 nurses providing 24/7 care, those 2 or 3 nurses can be really working 24/7 to manage the COVID-19 response. And that's the type of strain that we're talking about. Dr. Roussin mentioned the rapid response teams. We do currently have 2 active deployments. Largely, these rapid response teams go in to support the testing workload because we use a lot of rapid testing devices in communities to help us identify cases and get them into isolation sooner. That's a workload that wasn't anticipated in the current staffing models for nursing stations or health centers. And that's why more often we hear First Nations communities requiring surge support sooner because, the remoteness, the baseline staffing levels are not the same as in a regional health authority where you maybe have multiple hospitals, multiple primary care centers where you can flex the staff a bit easier.
And Dr. Roussin, when the vaccine mandate was first announced in August, you said that you'd be keeping an eye on staffing. So I'm just wondering why there wasn't a plan to help out care homes in areas with these low vaccine rates.
Yeah, I think there's a plan. There was a plan in place, and there's certainly anticipation of issues with staffing once this mandate took effect. So, the specifics of that can be directed to Shared Health, but there's certainly a anticipation and plans in place.
From the Brandon Sun, Kyle.
Good morning. This question is for Dr. Roussin. You said at the beginning of this conference that being vaccinated is the best way to protect yourself and others against COVID. But a recent COVID bulletin that was put out on October 12th kind of reminded the public that exemptions from self-isolation or quarantine are in place for individuals who are fully immunized or recently infected with COVID-19 in the past 6 months. I was just wondering, is this a new public health order, or is this something that's been in place throughout the whole pandemic?
No, that's been in place for quite some time. Certainly, the exemption for vaccinated people have only been in place since we've had the vaccine available. For those that are recently recovered, we've had that at 3 months for much of the time, and that's what the evidence early on was showing that we were confident was. Now we're confident that a 6-month duration after recovery is likely safe. So we've expanded that.
Okay. And I guess, do you think it's wise to kind of, I don't think you guys are equivocating the two, but do you think it's wise to put those kind of so close together just because people are using natural immunity to, delay getting vaccinated? They kind of do use that excuse. So do you think it's a good decision to put those two so close together?
Yeah, and so when our messaging, we always have to be careful with the many things we message. This is another one here. We're not equating vaccine with natural immunity. Everyone who's recovered from infection, we still recommend you get vaccinated. We see much better protection in those that are vaccinated for a longer duration. So definitely it's not the message we're sending, but it is our move where what the science was telling us that we could expand that period.
We now return to the news conference theater.
Dr. Roussin, Saskatchewan asked Manitoba for help in terms of taking some of their patients. Ontario has agreed to do so. Do you know what's happened with Manitoba? Has Manitoba said yes or no?
I don't have specifics on that. That should go to Shared Health. We're certainly still very appreciative of Saskatchewan's help during our third wave, but any details about the sort of the clinical resources should go to Shared Health.
Dr. Anderson, I have a couple more questions about the third dose program. So, given what we're seeing with breakthrough infections right now, how do you expect this trend to evolve over the coming months? Are we going to see increased numbers of breakthrough infections and perhaps hospitalization as a result?
We may. Part of what we will see in First Nations will depend on what we see in the province overall as well. And I think, part of the challenge when we just look at numbers, which is what I was able to present today, is it doesn't show how the overall rates of infection in fully vaccinated people remain much lower, although the overall rate of severe illness in fully vaccinated people remain much lower. Because like I said, when over 90% of our population has at least one dose, the total number of fully vaccinated people is much higher than the total number of unvaccinated First Nations people. So I think what has been seen in a number of jurisdictions is as that full vaccination coverage increases, the number of cases you see amongst fully vaccinated people, just because there's so many more of them, also appears to increase. What I'm hoping is that we'll continue to see protection against severe outcomes. So, in the past, we've talked about often how First Nations people made up 50 to 60% of hospitalizations or ICU numbers. I hope that when we advance this recommendation for First Nations communities, focusing first on our elders, who we know are going to be at the highest risk of those severe outcomes, that we will continue to see a lower proportion of First Nations people in hospital that we did at the height of the third wave. And then I'm also hopeful that this boost to the the immune system of people who have been fully vaccinated will help us to decrease transmission in the communities and ultimately, hopefully, dampen the impacts of the fourth wave overall.
And so far, you're still seeing that the severe illnesses are not, we're getting breakthrough cases, but you're not seeing the severe illnesses, correct?
I would say last week we did start to see some more severe outcomes amongst those fully vaccinated as well. And that's part of the reason, even though it's low numbers overall, it's part of the reason why we don't want to delay this announcement now. We're starting to see it. Let's get those third doses out there and hopefully start to reduce those numbers again.
Is there any consultation with other like First Nations health authorities or administration in other provinces about what they're seeing on reserves as far as breakthrough infections go?
I do have regular contact with the other MOHs working with First Nations Inuit Health Branch across the country and my colleagues in First Nations Health Authority, like you have said. And you know, NACI has acknowledged for a long time that Indigenous communities, particularly remote communities, are higher risk. And I would say the discussions that I've had have been consistent with our experience here. It's not isolated what we're seeing in Manitoba.
Dr. Roussin, what would you say the minimum period would be for the current vaccine mandates to be in place for? Or can we expect it to be at least, say, the winter, and then your department would assess at that point?
Yeah, and so it's tough to say for sure, but I think we have to expect that this would carry us through the typical respiratory virus season, so through winter into spring. Obviously, we review all these things all the time, but I think given the state of our healthcare system and the demands that the respiratory virus season will be likely to put on it, it's very likely will have to take us through this winter.
And that's all the existing ones. So, for example, the vaccine requirements to enter certain public places, as well as the vaccine requirements for certain professions, healthcare.
Yeah, I think that's what we would anticipate that right now. You know, of course, if things change, we would always evolve with what the evidence is showing us.
Dr. Roussin, do you see down the road the third dose being a requirement to get a vaccination card? Because that would mean an unvaccinated person would have to wait at least 7 months to be eligible for a card.
So this isn't something that's in the works at all right now. So in all of the eligible people now for a third dose, it's a recommendation to them, providing the reasons why. It's not affecting any of their considered vaccine status, though.
And are we still on the severe trajectory for our fourth wave?
Well, we've seen that trajectory up to a couple weeks ago onto the severe trajectory. The rate for, say, the ICU admissions as of last week, we're still on that trajectory, but at the low level of the confidence interval of that. So. So we still have to see over time where that trend will take us. So, we're certainly still at risk of those severe outcomes.
Dr. Roussin, it's been about 3 weeks since we had our first large-scale events, 15,000 people going to a Jets game vaccinated, 2 games, and there was a concert after that. Has there been any evidence of infections that have been tied to those large-scale events?
We have not been able to, tie any transmission to those events. So again, there's some complexity with linking up cases when you have that many people in an event, but certainly haven't seen any significant transmission there.
If there were cases, it would show up somewhere, though. If there was a number of infections, if there was a lot of transmission that occurred at an event like that through contact tracing, you'd pick up some of it, wouldn't you?
You'd at this point, especially given our relatively low numbers in Winnipeg, we would be able to pick up on trends if people were cooperative with the contact tracing, which we would expect. And so just overall, we have relatively low case numbers period. So if we started seeing that trend, we would definitely be looking at those events.
We have time for a couple more questions.
Dr. Anderson, do you have a message for First Nations people who hear about but a absolute number of breakthrough infections that are occurring on reserve, and then how they can take that into consideration with whatever hesitancy might exist, which we know it's everywhere in the province, but also on First Nations. So how do they Yeah, that's true.
So the main thing I want to reinforce is that every dose of this vaccine is important. Those first and second doses have been critical where we've seen them in reducing severe outcomes. That we saw that definitively in the third wave. And now we believe this third dose and getting it sooner rather than later will again boost that immunity and further protect our communities. So the main thing that I want to say is this third dose is consistent with what we've seen so far and with the safety and effectiveness of the vaccine, and we just want to boost it up yet again as we're experiencing the fourth wave in First Nation communities. But every dose is important.
Dr. Anderson, though, how do you combat some folks, the anti-vax crowd that will see, these higher number of breakthrough cases and say, maybe question the effectiveness of the vaccine? How do you, maybe to go off my colleague's question, how do you combat that?
I think to emphasize again, and Dr. Tams put this out in the Public Health Agency of Canada bulletins, it's consistent with what we've seen here. The risk of a COVID-19 infection if you're not vaccinated is 10 times higher than if you're fully vaccinated. And as of a couple of weeks ago, the risk of being admitted to hospital or experiencing a severe outcome if you're not vaccinated is 38 times higher than if you're fully vaccinated. So while we want to boost protection for those who are 6 months out or more amongst First Nations people, that's because we want to maintain the effectiveness of that vaccine.
You mentioned earlier the second dose uptake is maybe a little lower than it is in other communities. As teams go into these communities, will you also be giving out second doses? How will you recruit those individuals?
So we'll work with the community on the messaging that every dose is important and every dose is available. And then we'll be working on, the technical side of things, of reviewing the data and making sure that we know how many people and how to target the information to those who need any dose right now.
Perfect. Thank you, folks.